MRI silent pathologies with dynamic MR testing of cervical spine, result of 30 cases, presented by Dr. Manish Kothari.
Good morning, everyone. Thank you for the opportunity. I'm Manish Kothari from Mumbai. No author disclosures. Now, the whole genesis of the study starts with the question, what do we do in patients with persistent neural symptoms but very mild-looking MRI? That's when we started looking at the role of dynamic MRI in this profile of patients. Hence, we included patients with radiculopathy and/or myelopathy, existing MRI showing no significant compression, no radiographic instability, and included previously operated patients as well. We excluded only axial neck pain patients, adjacent segment instability, non-lesion pathologies, and those who could not complete the study. We used a very simple technique for the flexion and extension MRI using bolsters, which can be reproduced in any center. We then collected the demographic, clinical, and radiologic data. For objective assessment of the grade or the severity of compression, we looked at the Moulet's grading. Moulet was the first one to describe grading system on dynamic MRI. Grade 0 being normal, grade 1 being partial obliteration of the CSF, grade 2 being complete subarachnoid block, and grade 3 being impingement or a pincer effect. In addition, we also looked at neutral mid-body disc height, total angular movement between flexion and extension, and change in posterior disc height between flexion and extension, and ligamentum flavum thickness in axial neutral scan. Coming to results, we had 30 patients with a mean age of 58 years. There were 23 primary and 7 previously operated patients. A good 83% of them showed new compression on the dynamic MRI. Out of the 21 initial non-operative patients, 16 became operative, and there was change in the number of levels of suspicion in the other patients. More than 80% had a complete change in clinical plan, which was significant. Coming to the type of compression, the anterior compression patients were mostly focal and worse on flexion, whereas the posterior and combined compression were mostly multifocal and worse on extension. We then compared levels with mild Moulet grade versus levels with severe Moulet grade, and compared them against mid-body disc height, angular movement, and disc height change, and that was not significant. However, the ligamentum flavum thickness in neutral axial scan was predictive of a worse Moulet grade on extension and dynamic MRI. Now, when these patients underwent surgery, the improvement in clinical scores was quite significant in the primary cases. It was better but modest in revision cases. For example, this patient with C3-4 cord signal but no significant compression, no radiographic instability, had significant compression on extension MRI, which needed a single level ACDF. Another patient with a myelopathy patient previously operated for laminectomy with initial improvement but came back with worse myelopathy symptoms. We did a dynamic MRI showing significant compression on extension. She needed a revision posterior decompression and posterior fixation. Now imagine if this patient was to undergo anterior surgery and was positioned in a lordotic fashion to regain the lordosis, what would have happened? So neck extension worsening spinal canal dimensions has been known in literature for many decades now. There are dynamic MRI studies, but most are in healthy volunteers or general degenerative cases, and many are radiological studies without clinical consequence. There are clinical studies with sitting kinematic MRI, which is not available everywhere. We have used a simple MRI technique and also tried to look at which neutral scan is going to have a worse dynamic image. Now, the strengths of the study were the inclusion criteria, where the limitations were there was no control group or the kappa values. In conclusion, supine dynamic MRI can alter the decision making in the clinical setting. A thick ligamentum flavum on neutral axial should warrant a dynamic scan, and surgical results in such patients is quite favorable. Thank you.
Paper 14, Preventing Distal Junctional Kyphosis, Choosing a Stable End. Thank you to all our presenters, and this final section is now open for discussion. We'll start with a question from our web app. This is for paper 13. Wondering, in your own practice, do you do flexion extension MRI for all patients? And if only selected, what criteria do you use?
Not in all patients. For a simple radiculopathy with a very clear clinical and radiological match, we don't do that. But for most of the myelopathy with a borderline compression, if there is a clear signal, hyperintense signal, then we do a flexion and extension. If there is a clinical radiological mismatch, then I would do a flexion and extension, but not for all patients.
Thank you. Microphone 1.
Question for Dr. Berger. Thank you.
Thank you. And then question for paper 13. You mentioned that if you have a T2 signal change within the cord at a level without frank compression on the MRI, that you go ahead and get the flexion extension MRI. Do you feel that that adds anything, or does the presence of T2 hyperintensity within the cord intrinsically indicate that there must be some sort of dynamic compression?
Right, it's very intuitive to have a cord signal, then there is a compression, right? But what we found was in some cases there was a single level compression which would undergo a single level surgery, compared to some which had a multi-level compression which would need a multi-level, mostly posterior surgery. I'm a lameloplasty guy. I love doing lameloplasties, so I would choose that.
Microphone 3.
Dr. Kothari, did you change your surgical approach after the dynamic MR evaluation? In any of your cases, did you change the strategy?
In, 16 out of the 25 patients, the initial levels were changed and even approach was changed. Now, approach cannot be kind of statistically checked because each surgeon is different, but we measured the number of levels operated, and that was much different from initial plan versus the plan after the dynamic MRI.
Is there a threshold for you by means of millimeters, for example, if you detect compression increased? Is there a threshold? Did you measure any?
We looked at 4 parameters. 3 were not significant, primarily because they were all severely degenerated levels, so measurements are not very reliable. But one of the parameters was positive, which was ligamentum flavum thickness in neutral axial scan. We could not really quantify the value, but looking at the standard deviations, we found that anything flavum thickening more than 2 mm should warrant a dynamic scan. Not necessarily it will cause a compression, but you should ask for a scan if the flavum is thick more than 2 mm on the neutral scan.
All right. If